Hi, this is my first talk today at the Crossecon. It's titled Pattern Recognition, Fibrosing and Non-fibrosing ILDs. Now, when we look at ILDs and we want to understand a basic approach, then these 4 points will help us do that. And the first and most important is making sure we understand the correct technique. And while we've had multiple new guidelines, this doesn't change. We need volume inspiratory scan, minimum 1 millimeter slice thickness, thinner is fine, at 0.5 millimeter intervals. We also need an expiratory scan in the supine position. Can be volume or incremental, but it's just faster to do volume. And in every patient who comes for the first time, and preferably in all patients, we should do a prone inspiratory as well. Some people try and combine these two by doing a prone expiratory, which I think is the worst of both worlds. And then make sure that all patients have soft copy access. And if you're filming, then it has to be 12 on 1 and not 50 on 1 or 60 on 1, etc. So that's the standard protocol. And when we get high quality images based on this, is when everything that I'm going to talk about now is um, is understandable and is something that then you can do on a regular basis when you're reporting these scans. So there are about 8 signs of ILDs: honeycombing, reticular opacities, traction bronchiectasis, which define the fibrosing ILDs, and ground glass, consolidation, septal thickening, ill-defined nodules, discrete nodules, and diffuse cystic lung disease, or cystic ILD as the new guidelines would like to call them, which are predominantly non-fibrosing ILDs, with the understanding that all of these signs of non-fibrosing ILDs can occur along with the fibrosing ILDs. So let's look at the fibrosing ILDs. Let's look at these 3 signs. Honeycombing is the presence of cysts with shared walls starting in the subpleural interstitium, extending up to the hilum, typically more than one layer. And we can see that really well here. Honeycombing is a specific sign. When present, it defines the UIP pattern, but it's not very sensitive because 2/3 of UIPs don't have honeycombing. But since honeycombing is so important, it is necessary for us to be able to differentiate honeycombing from other conditions that present with cysts. So this is the list here. And on the left is honeycombing, on the right are those other conditions. So here we have branching cystic disease from the hilum to the periphery, which is typical of bronchiectasis. Here we have cysts without walls next to these vessels. This is centrilobular emphysema. Here we have a smoker who has centrilobular emphysema and a single layer of cysts at the periphery. So this is paraseptal emphysema. And this patient has diffuse cystic lung disease because you have cysts with walls that are randomly distributed throughout the lung parenchyma. Traction bronchiectasis can sometimes look like honeycombing, especially if you're not familiar with these concepts. But the moment you look at the sagittal images, you should be able to differentiate traction bronchiectasis from honeycombing. Now, traction bronchiectasis, therefore, is also a sign of a fibrosing ILD, and you can see that here: irreversible dilatation of the bronchi and bronchioles in the presence of reticular opacities. Now, this is a sensitive sign, which means that when you see traction bronchiectasis, it always implies that there is a fibrosing ILD, except in acute lung injury, of which COVID-19 was the classic example, where we now know that when you have an acute lung injury like this, there is a phase at which point you may see what looks like ghastly fibrosis with so-called traction bronchiectasis, but which can be completely reversible, as we saw with COVID. And this was a 9-month gap between the first episode and then follow up. And therefore, we started and we do use the term transient bronchial dilatation and not traction bronchiectasis. Reticular opacities are linear opacities typically touching the pleura, forming a net-like appearance, and invariably a very lacy kind of appearance. Now, this encompasses the terms of intralobular interlobular interstitial, and septal thickening. It's easier to appreciate reticular opacities when they occur with traction bronchiectasis and honeycombing. So we see these reticular opacities, we also see traction bronchiectasis. Then we know that we're dealing with a fibrosing ILD. And here we have reticular opacities and honeycombing. We also see traction bronchiectasis. Remember that in every patient who has honeycombing, there will also be traction bronchiectasis, though the reverse is not true. These reticular opacities, when they present with this interlobular septal thickening, can look like a confluent hexagonal pattern. And this is often more common with fibrotic hypersensitivity pneumonitis. But this is what a reticular pattern looks like. Now, once we see these three signs, which tell us there is a fibrosing ILD, we then put the signs together. And if we see reticular opacities, honeycombing, traction bronchiectasis, subpleural basal predominance, and nothing else, then that implies a typical usual interstitial pneumonia or UIP pattern. The same findings, but without the honeycombing, would be the probable UIP pattern. And UIP without etiology then becomes idiopathic pulmonary fibrosis. And so if you have both of these, nothing else, no etiology, then we can put it into this 4-bucket classification which came out in 2018 and hasn't been changed, and that becomes IPF. However, if you have UIP with an etiology, then that's a secondary UIP, and it would be that condition-related UIP pattern. So this 27-year-old with a UIP pattern is honeycombing, subpleural basal predominance, reticular opacities, but has esophageal dilatation and is a known case of scleroderma. So then this is scleroderma ILD with a UIP pattern. Or the 66-year-old man has a probable UIP pattern here with traction bronchiectasis, reticular opacities, but no honeycombing, but also has these pleural plaques, in which case now this is a secondary UIP due to asbestosis, and the patient used to work in a brake lining factory. Then we have UIP-like but non-IPF patterns. And so here's this patient who has honeycombing, traction bronchiectasis, subpleural basal predominance. So far so good. But as we start going towards the apex, we see that there is an axial distribution from the hilum to the periphery. We're seeing ground glass, we're seeing ill-defined centrilobular nodules, we have upper lobe bronchocentric fibrosis. When we put all of this together, clearly this is not your standard UIP pattern, because in the UIP pattern you should have nothing else. You should have subpleural basal predominance. So this is non-UIP, but it's a fibrosing ILD. So fibrosing ILD non-UIP means it has to be either fibrotic hypersensitivity pneumonitis or chronic pulmonary sarcoid or a pneumoconiosis or some such other diagnosis, including connective tissue disease. Now, this patient has reticular opacities, has traction bronchiectasis, has a little honeycombing, but it's all upper and mid-zone predominance. The lower lobes are completely spared, and this therefore is a fibrosing ILD, but it's non-UIP, and you would need to find another diagnosis, and this was typical of chronic sarcoid proven on biopsy. So that's the next bucket where we have a fibrosing ILD, but there are other findings that tell us that it's not going to be UIP IPF, but it's going to be something else. Now, a bucket that hasn't been well defined so far and will change later on in the guidelines is variant fibrosis, where you have a UIP like pattern but many unusual features. And these unusual features immediately raise flags for an underlying connective tissue disease. And I'll just look at 5 of these here. Exuberant honeycombing. So this is a UIP pattern. But there's so much extra honeycombing, almost, and it involves more than 70% of the lobe. This is typical of connective tissue disease ILD, especially rheumatoid arthritis. Or when you have exuberant honeycombing in the non-dependent upper lobes, where it's called the anterior upper lobe sign. Again, you'll see this with RA, scleroderma, SLE, and other connective tissue diseases. Or you have island-like fibrosis. So there is honeycombing, there are reticular opacities, traction bronchiectasis. This is like a UIP pattern, but the very sharply demarcated, triangular shaped, as if this was the result of a prior infarct. And this is what we get with the vasculopathic CTDs such as SLE and scleroderma. And when we get island-like fibrosis in 4 corners, anterosuperior and posterior-superior, as you can see here on the sagittal images, then the 4 corners sign again tells us that there's underlying connective tissue disease. The sign that works best in day-to-day practice is the straight edge sign. And you can only pick up the straight edge sign if you look at every patient in coronal and sagittal images as well on the workstation. And once you see the straight edge, it tells us that we're likely dealing with an underlying connective tissue disease. And this is the straight edge of a connective tissue disease ILD. And you can see in the UIP IPF how there are undulating margins and no straight edge. That brings us to an entity called interstitial lung abnormality, or ILA. And this is a new hot topic buzzword, and everybody wants to do research on this. And in April 25, we had updated guidelines. So these are non-dependent lesions, and it could be any of the signs of an ILD. And you obviously have to confirm these on prone imaging, involving less than 5% of the lung and not meeting criteria for ILD. But what this basically means that you usually have an asymptomatic individual in whom you have picked up interstitial lesions that were not suspected. Or you may pick it up on screening when you're, let's say, a patient with rheumatoid arthritis or scleroderma. We do a CT. Patient is completely asymptomatic and we find these lesions. So here we have non-subpleural ground glass, subpleural non-fibrotic, subpleural fibrotic, this traction bronchiectasis here. But in an asymptomatic patient, incidentally picked up, we use the term interstitial lung abnormality. Sometimes as a radiologist, it's very difficult to know whether or not the patient is symptomatic, etc. So you can use the term ILA/indeterminate ILD when faced with such a problem. But you should also know what is not ILA. So respiratory bronchiolitis in smokers, dependent densities that disappear on prone images, interstitial edema when you have bilateral pleural effusions and ground glass, changes of aspiration in patients who have a hiatus hernia. And here you see centrilobular nodules. You're not seeing reticular opacities. And these friction fibrosis, so periosteophyte changes here, this is not significant at all. Now that, once we talked about connective tissue diseases, would bring us to NSIP. And NSIP is a specific entity. It's not a basket case saying that, okay, we don't know what's going on, it's non-specific, let's call it NSIP. It's a defined entity where we get reticular opacities, traction bronchiectasis, subpleural basal predominance, but often subpleural sparing, as you can see here, and there's temporal and spatial homogeneity. So the lesions look the same in whichever section that you look at. So NSIP can be both fibrosing and non-fibrosing. It may precede full-blown connective tissue disease by a few years, but idiopathic NSIP is extremely, extremely rare. So just to understand the concept of subpleural sparing, right? This is a patient with UIP. There's no subpleural sparing, and here you see a patient who has this subtle subpleural sparing, better appreciated on the sagittal images. Now, half of the NSIP patients will have subpleural sparing. So in those half, it should be easy to make that diagnosis, which generally means that the patient has underlying connective tissue disease. Then we have this pattern in a fibrosing ILD called reverse UIP IPF. And that is when you see a UIP-like pattern but in the apices and the upper lobes. This patient has bilateral pneumothoraces, and this is a condition called pleuroparenchymal fibroelastosis. It's a progressive upper lobe subpleural fibrosis with loss of elasticity, presence of elastin. And like with all conditions, it can be idiopathic, primary, or secondary. That then brings us to the non-fibrosing ILDs. But please remember that when I showed you the non-UIP patterns where we had UIP-like and then you had ground glass nodules, etc., cystic change, when the non-fibrosing patterns can occur as part of fibrosing ILDs, in which case they become fibrosing ILDs. So these are purely non-fibrosing ILDs where there is no evidence of traction bronchiectasis or honeycombing. So first is ground glass, which is increased density that does not obscure the underlying vessels. And this is a completely non-specific sign. Now this same pattern that you see on the right can occur in all of these conditions. So if the patient is subacute non-smoker, it could be hypersensitivity pneumonitis. In a smoker, it can be DIP, RB, ILD. DIP is now called alveolar macrophage pneumonia. Acute could be acute interstitial pneumonia, which is now called acute lung injury, and in a patient who is HIV positive, this would be PCP, PJP. Now, ground glass can occur on its own, or it can occur with additional findings. So, ground glass plus air trapping that you see here is typical of hypersensitivity pneumonitis. Now, that often presents as the 3 density or the triple density sign, which earlier used to be called the head cheese sign, where we may see normal lung, lucent lung, and ground glass in the same image or the same section. And when we see that, if there's no traction bronchiectasis or honeycombing, this would suggest non-fibrotic hypersensitivity pneumonitis. And when you have traction bronchiectasis and honeycombing, then that suggests fibrotic hypersensitivity pneumonitis with a reasonable specificity. Then we have ground glass plus consolidation. Now, that typically would mean an organizing pneumonia pattern. And you have different patterns. They can be subpleural, bilateral, you can have peribronchovascular, you have the reverse ground glass or the atoll sign, and then you have the peripheral reverse bat swing. So there's ground glass here and consolidation at the periphery. And we saw a lot of these organizing pneumonia patterns during COVID because COVID presented in this manner. So that was a learning experience of how different manifestations of OP can happen. Then we have ground glass plus septal thickening, and this is the crazy paving pattern where we have ground glass and septal thickening, normal intervening lung, and this typically occurs with alveolar proteinosis. And we saw these patterns also with COVID, but at that time they were more focal or multifocal rather than being diffuse and reasonably symmetric as we get with alveolar proteinosis. We learned of another pattern during COVID, and that was perivascular ground glass. So here is a patient who has a vessel and then there's ground glass with a feathery pattern around it, which basically occurs whenever you have a vascular inflammation. So COVID had direct involvement of the lungs, and then it had this angiopathic component, which is what we saw there. And in those patients, you would see these proximal dilated and intralesional dilated vessels. And that was why we got the target sign. So you had a vessel in the center, Then you would have perivessel or vascular inflammation. The spared lung was actually hypoxemic lung, and then or hypovascular lung, and then the ground glass halo of edema and compressed lung parenchyma. The next pattern is septal thickening. So you just get septal thickening without anything else. So we earlier talked of ground glass plus septal thickening, which is your crazy paving pattern, but this is only septal thickening. And so septal thickening here, you may get a little bit of perihilar ground glass. The first time that I'm showing you effusion here, so this would be pulmonary edema. And proof of the pudding, we gave diuretics, 36 hours later, patient came back and everything's gone. Septal thickening, normal intervening lung, some nodularity only in the right lung in the presence of a lung mass. This is lymphangitis. And so I did do this earlier, and I put it up at ctchestreview.com, where I created a flow chart of ground glass and septal thickening, where you have only septal thickening, classic crazy paving, and then ground glass and septal thickening, and then depending upon whether it's acute, chronic, additional findings, you can try and come to a diagnosis. If you want to do a deeper dive into this, then you can check out this post. Then we have nodules, and nodules are ill-defined centrilobular or discrete. When we see ill-defined non-branching centrilobular nodules, it's almost characteristic of non-fibrotic hypersensitivity pneumonitis, whereas discrete nodules typically can be perivascular, they can be fissural, subpleural, and this is most commonly seen with sarcoid. Sarcoid nodules, especially the fissural ones, are better appreciated in the coronal and sagittal plane. So again, every time we see diffuse lung disease, we must get into the habit of looking at these scans in the coronal and sagittal planes. Then other discrete nodular diseases, and I'll show them to you and then I'll come back to the chart. So you have all of these that you have to consider when the predominant pattern is nodular disease. And this is a flow chart that I had created 3 or 4 years ago, and then I've re-updated it. And again, I did a post on this. No, I didn't. I will probably do one. But there is an earlier post at ctchestreview.com that talks about an approach to small diffuse lung nodules. And again, it depends on the pattern, the appearance, etc. And you can then try and come to a diagnosis. And I use this myself when I'm reporting these scans to try and differentiate among all of these entities. Some patterns are just etiology and disease-based patterns. So let's say you have a smoker with a 20 pack years history of smoking, then you know that you're dealing with a whole bunch of different conditions. And this patient has said, this is a single patient with so many findings. There's centrilobular and paraseptal emphysema, the ill-defined branching centrilobular opacities of respiratory bronchiolitis. There are associated reticular opacities, so it's RB with fibrosis. We have these reticular opacities, which would mean smoking-related interstitial fibrosis. And here we have these large cystic areas with that stalactite, stalagmite appearance, telling us this is airspace enlargement with fibrosis or AEF. And this combination of emphysema with interstitial lung disease is called combined pulmonary fibrosis and emphysema. So again, a lot of terms that I'm bandying around. But if you need to do a deeper dive, then these are all the conditions and names that you would need to know about. Or insult. Let's say a patient is on a known drug that is known to involve the lung. So this patient was on nitrofurantoin, lands up with an organizing pneumonia pattern, nitrofurantoin removed, patient's fine, again introduced, again has an OP pattern. So this would be drug-related interstitial lung disease or drug-induced interstitial lung disease. The same thing happens with radiation. So this patient received radiotherapy for CA breast. You see this classic subpleural reticular opacity pattern with a little bit of traction bronchiectasis. And then over time, it becomes less and less, and you can pick it up only if you know of, you're very sharp and you have an understanding of this process. then you will pick this up. And nowadays, now the new guidelines talk about this being radiotherapy related lung injury. So that was a basic approach, a pattern approach to ILDs, where you first need to identify what the pattern is, obviously assuming that um, the scan is of top quality, and then figure out whether it's fibrotic, non-fibrotic, and then within these figure out what pattern it fits into. And I do, this is the current algorithm that I'm working with, um, that allows us to get an understanding. I did do a post on it at CT Chest Review. If you're interested, go through that. And thank you so much for viewing this.